Hi guys, we're going to start talking about the chest today. So these three links are the ones I'm going to refer to this week. They're in your course under references, research, helpful links under Module 5. So normal chest CT contains traumatic aortic injury and traumatic aortic injury. So let's start with a normal chest CT. Let's start with there's two different axials and two different coronal reformats. So let's start with our soft tissue or normal window of our axial. So let's start all the way at the top. And the first thing I want to look for is the thoracic inlet. Okay, remember the thoracic inlet is the most superior opening of the thoracic cavity that allows for nerves, vessels, and the airway to travel from the thoracic cavity superiorly up into the neck and then the brain. So the thoracic inlet is bordered by the first T-spine, so the first thoracic vertebrae right here, and it's going to border laterally by the first rib, which is right here. That's going to come around, and it's going to articulate with the manubrium right here, the most superior portion of the sternum. So manubrium right here, first articulation is going to be your first rib. Don't get it confused with the clavicle, which is right here. Okay, you know how you have to do a couple slices up and down to start to orient yourself. It's very easy to confuse this with the medial anterior border of the first rib, and it's not. This is the first rib articulation. Follow it back, 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 back. There's your first rib on T1. Okay, so that's your thoracic inlet. It's an opening that kind of is like a circle that kind of is on an angle down, I guess. All right, and that's because we're seeing the superior posterior portion of the thoracic inlet here, and then it's traveling around and it's going here and articulating with the manubrium. Okay, so then we have to scroll down through the lungs, and then our thoracic outlet is down here. Okay, the lower ribs, the 12th rib coming around, and it's kind of like an opposite circle that's tilted in the opposite direction from the 12th rib around, and then the cartilage that articulates, you're going to see this is all cartilage up in here, that is going to come up and articulate with the xiphoid, which you can see right there, and then the inferior border of the body of the sternum. Okay, and this is all costal cartilage. Can you see this all in here? And it's got little calcified, which you guys have all seen calcified cartilage on a chest x-ray. Now you can see it on a CT. It's just much more, the resolution, the contrast resolution is just much better. So that is your thoracic outlet, okay? So this is the most superior portion is on the anterior side in the thoracic outlet. And then if we follow that inferiorly, it's going to be the ribs and the 12th rib right here. Okay, there's your thoracic outlet. All right, so let's go back up to the top. And now let's look at the joint spaces. Find a good slice here of our rib. Here's a good one right here. The posterior articulation of the rib with the thoracic spine. Okay, so you have the body, the transverse process, and then we have our articulation here. We have two different joint spaces. We have the costovertebral joint space right here, the most medial articulation, and then the costotransverse is right here. Okay, there's your costotransverse. So those are two joint spaces you should be able to see on most levels of a CAT scan of the chest. We could talk about the parietal and visceral pleura. Let's switch over to our lung window and see if we can see them. And remember, it's going to be very difficult to see the distinction between those two linings of the thoracic cavity if there's nothing that's occupying that space. And actually, you can kind of make out here, see this very thin black line here, there is a little bit of air in the space, or maybe thickened fluid in the space between the visceral pleura, which is the lining directly on the lung tissue, and the parietal pleura, which is on the posterior border of the thoracic wall back here. That lines the thoracic cavity. Okay, remember there's serous fluid that's in between the two of them. So you can kind of very faintly see that there's two separate lines here, and the very outside lining of these two distinct spaces would be the parietal pleura, and then the lining directly on the lung is going to be the visceral. All right, so not really the best one to see that, but we'll look over at our traumatic cases in a second, and I bet you'll be able to see the linings there. Let's scroll back up. Let me switch back over to our standard window. And let's go look for the trachea, which should be, hands down, one of the easiest things to see. In the neck, the circular dark space is the air-filled trachea. You're going to follow that down inferiorly, and at one point, it's going to branch, there you go, into two separate bronchi. Those are your right and left main stem bronchi right there. And this is otherwise known as the carina, right? And I'll show you that on the coronal view as well. This is a very important landmark. It's very easy to see on most CAT scans, the coronal view. And if you look at, when you look at the vessels that are surrounding this area, I can distinctly see the carina, and just one slice down from where the trachea branches, I have my main stem pulmonary branch coming out here. This is your main pulmonary artery. And if I keep going down, I have my right and left main branches, which we'll go over this circulatory system here next week. But for a CAT scan tech who's looking for a PE, which is a thrombus in the pulmonary artery, a pulmonary embolus, this is where you're going to be looking, all right? So understanding that it literally is millimeters inferiorly from the level of the carina will help you to locate it when you have to do certain ROI slices to make sure that we have enough contrast in these vessels right here. It's also going to help you find these vessels. If you're not sure and you can't just like scroll down and say, oh, there's main stem, there's right branch, there's left branch, look for the carina, follow it down, follow your trachea down, first branch. The first thing that's going to pop up is your main stem, your main branch, and then it's going to kind of look like a guy running with his hair on fire a little bit, okay, with his two legs here. All right, so your right branch and your left main stem bronchi. The other thing I want to point out is, let me go back up. Here's trachea, branching, here's right main stem, left main stem. The first thing I want to show you is if I go one slice down, I want you to see how the left is starting to kind of go over. So if you can imagine, if I'm seeing it on a longer slice or an oblique kind of view, this branch is starting to go over transversely. It's moving over faster this way, so it's not as up and down. Whereas if you look at the right is still clearly up and down. So this is what we talk about when we say that when you're looking for a foreign body that is potentially going to enter the lungs, or aspiration pneumonia typically is going to happen in the right lung. That's because the trachea, as you go down, you have this nice tunnel that goes straight down, whereas in your left branch, it's going to take a turn, all right, and it's going to start going over, and something's going to collect where it would have a much clear shot in the right branch. So that's your right main stem bronchi, left main stem bronchi, and then you can follow it as it starts to branch again. There's another branch into your lobar and segmental, and all the way down into your bronchioles and then your alveoli. So for a test, I'm not going to make you know lobar, segmental. I do want you to know trachea. I want you to know carina, right and left main stem bronchi until the right and left branch their first time. Okay, so that would be something you would have to know for a test. Let's switch over to our lung window and look at the same thing. And I want you to see, too, the difference between the soft tissue window and the lung window, the look of the lungs, which you should have noticed this already, but you can actually see when we have the lung window on, as we travel down the right and left mainstem bronchi, you can follow the secondary lobar and the tertiary. You can follow, look at these little black dots as they travel all the way down, smaller and smaller, and then they eventually get too small that your eye can't resolve how small they are in diameter. But you can see how they branch and branch and branch and branch all the way down into the tiny little crevices of the lung tissue so that we can have that gas exchange at the alveolar level. Okay, and you can't see that on your soft tissue. It's not there. We know it's there, but you can't see it. You can kind of see the vessels here that are filled with blood, so we can definitely see them. We can't see the bronchioles and stuff. So that's why a lung window is really important. Let's go over and start talking about the lungs. Obviously, we have right lung and left lung. Okay, it's in an anatomic position. First, let's just look at the lungs, their shape of their lungs, of the two lungs. And I want you to notice as we scroll down how you have this clear notch over here on the left side that's going to start to grow. That's your cardiac notch of your left lung, okay? Because your heart sits kind of to the left of your mediastinum, okay? Cardiac notch. There's your cardiac notch. And then this kind of tongue-shaped piece of your left lung up here, that's the lingula of your left lung, okay? Something else you should be able to see on an axial slice. So cardiac notch, lingula, and then the area of the lung with the indentation where all the guts and the good stuff goes in and out, right here, here, that's your hilum, okay? Hilum, right hilum, left hilum, okay? So that's where the blood vessels and the main the mainstem bronchi and then bronchioles branch off into the other areas of the lung. So the indentation in the lung that allows for the tubes and vessels and everything to go in and out of those organs. What is kind of hard to see, we're kind of seeing it on this axial slice, is the fissures. So we know that the fissures are there, but we're kind of hitting them in an angle that you're not really seeing them clearly defined. So the thing that I do want you to see on the axial here is as I scroll up and down, do you see this like blurred kind of line here? That's us seeing these fissures in a weird plane. See this blurred line? Okay. So those are the fissures, but I want to switch over to the coronal lung, and boom, I want you to see right lung, there's your right horizontal fissure, and here's your left, or your right oblique fissure right here, and see how it has that blurred look to it? It still has that blurred look to it here. Okay, so right horizontal, right oblique. And here is your left oblique. It's not very clearly visualized, but you can kind of follow this. Where is it? You can kind of follow this. I'm seeing it anteriorly here, and it's kind of traveling up as I travel posterior through the lungs, but I'm not getting it on a good slice. Here's a bit of it right here. Okay, so there's your left oblique fissure, right? From this view, your left lung, here's your cardiac notch. Oh, hold on. Lingula, there's your lingula right there. I have to stop and come back to this in a second.